First, thanks a lot for the opportunity to give this presentation about liver transplantation in advanced HCC. So I work in Paul Booth Hospital, a famous place for liver transplantation in Europe. This is my link of interest because of my lab of digital innovation in the OR and especially in the field of AI. So, total hepatectomy finally is the best way to have good margin, and obviously if you change your liver, you decrease a lot the risk of de novo HCC. So clearly, liver transplantation is historically the best treatment of HCC. And obviously, if you have a recurrence of HCC after the liver transplantation, it means that there was micrometastasis the day of liver transplantation. But you see that the result at 10 years was more than 51%. So clearly, liver transplantation is a fantastic treatment of liver cancer. So obviously, to be able to perform transplantation, we need to have a graft. And in Europe, it is obviously a problem because we do a lot of cadaveric donor, but very few living donor. So we need to conserve graft only for patients who need it, and we use it for a long time. So it's important to consider the result of transplantation comparatively to other treatment like resection and propose the transplantation to patients who have a lot of gain due to liver transplantation comparatively to resection. And we need to use for a long time, it means we need to select patients with a recurrence after transplantation. And you see that in France, there is less than 10% of patients was finally transplanted for HCC. And you see that this is an interesting paper published in Annals of Surgery that compare the capacity to cure patients with hepatocellular carcinoma, and you see that despite a dropout of 20%, very high dropout in the field of liver transplantation, there is clearly an advantage of liver transplantation comparatively to liver resection when you have a single big tumor or more than three tumors. And clearly, the problem is if you want to transplant patients with large tumor and with a lot of nodules, there is a risk of poor result because there is extrahepatic metastasis when you decide to perform the liver transplantation. And due to this, the way to select patients for liver transplantation, it means the absence of extrahepatic metastasis was related to the number, size, and alpha fetoprotein. And you know this famous scoring, Mazzaferro, and after USF criteria, and recently the alpha fetoprotein score. And in the last point, we consider not only the number and the size, but also the rate of alpha fetoprotein. So clearly now we use this number, size, and alpha fetoprotein. But we know that it's very useful to use TACE and or local destruction to be able to downstage the patients to reach a liver transplantation criteria works. And this is a randomized study published in the Surgical Oncology or Lancet Oncol that have compared policy of downstaging and after liver transplantation when you are outside the Milan criteria versus only downstaging. And clearly there is a massive impact of downstaging. So this is a proof that there is an interest to propose downstaging to reach liver transplantation criteria, and it works. And it works, but we need to be very, very cautious with the alpha fetoprotein rate, and the alpha fetoprotein rate is the best gatekeeper. And we see that when you have an alpha fetoprotein was more than 100, there is a risk of dropout, and even with a lower threshold, there is a risk of dropout. So clearly, we need to use the downstaging protocol, but we need to focus on the rate of alpha-fetoprotein because this is a very important factor for the risk of dropout. And in the recent consensus guidelines published in Hepato, you see that when there is an alpha-fetoprotein more than 1,000, this is an absolute contraindication to liver transplantation, regardless of the tumor burden. And it's very important to downstage the patient to Milan criteria, but you need to have an alpha-fetoprotein equal to 1,000 for at least 3 months before to be listed. And this is very important because if you don't consider that, you will have a lot of recurrence after. And a paper published by Patricia Tabriz in JAMA demonstrated that despite a long time, at 10 years, it works. It's possible to downstage patients, and it's worked for a long time after liver transplantation. So clearly, the downstaging to be able to reach the Milan criteria is efficient, and we need to use it. And it's important to see that it's a way to select patients, and it is interesting to see that there is also an interest when there is a pathological response, and this is a big paper published in Annals of Surgery, a lot of patient multicentric study with a very few rates of malignant portal thrombosis on the specimen. It means that today the portal thrombosis was a contraindication to liver transplantation, and you see in this series that we multiply by 3 if there is not a complete response on the specimen, and there is an impact of overall survival. And it is interesting to see that the neutrophil lymphocyte ratio was important to predict the complete response of the specimen near from female and alpha-fetoprotein. Today, there is no place for liver transplantation upfront or after downstaging in such situation. When you have a patient with portal vein thrombosis and in hepatic vein thrombosis. But we see recently some papers that open the door of liver transplantation in this field. And this is a paper published by Everton Swin. This is the discussion between pro and con, and they conclude that based on available evidence, it's too early to open the door, but clearly there is something to explore. And it is interesting because we know that if we consider the result of liver surgery, especially upfront surgery, in this situation, this is a very poor result, and globally around 15% of 50% survival at 5 years. So clearly, I think it is a mistake to operate patient upfront in such situation, and perhaps there is a way to consider downstaging and after transplantation. And this is a very important study published by Chinese, where there is a lot of patients that finally have been transplanted with VP1, it means sectorial or segmental portal vein thrombosis, or pedicular. It's important to consider that there is no portal trunk invasion itself. This is only inside the liver, pedicular or segmental, and you see that there is only local regional treatment and no systemic treatment in this series, and the result was interesting with 51% of survival at 5 years. So clearly there is probably a place when there is only pedicular invasion. And there is also small papers that come from Italy and come from Taiwan, that you see that VP2, VP3, small number of patients, but there is acceptable result, and we select patients with PET scan to exclude patients with extrahepatic metastasis, but obviously we need to further study to be able to consider more traditionally this population. And there is also a paper published by Italian people that evaluated the interest of liver transplantation after radioembolization after TARE. And you see there is 5 patients among 17 have been treated and transplant with correct survival. And you see that the rate of alpha-fetoprotein is really, really important to be able to select patients who could be transplanted, and we found again this. But if we check as the last clinical practical guidelines, the management of hepatocellular carcinoma, you see that in the group of transplant candidates, there is something about beyond extended criteria. What about beyond extended criteria? Probably is portal thrombosis and experimental protocol. Experimental protocol is systemic treatment using ICU and with Trema, Durve, or Beva, Atezolizumab, with very, very now efficient results. So clearly, we opened the door with systemic treatment, perhaps to propose a transplantation after. And this is a very recent paper published in JPATOL, and this is a mixed case. There is around 100 patients who have been transplanted, and probably there is a lot of patients with portal vein thrombosis in this group, and you see that the outcome is correct with a very small long follow-up, so be aware of that. And there is around 10% of recurrence. But what is interesting, it is there is obviously a risk of liver transplantation, of liver on allograft rejection when you give immunotherapy before the transplantation, and this is an issue. But we know that we need to stop the treatments at least 3 months before the liver transplantation, and perhaps to do a switch for lenvatinib as an example. And if you do that, there is a low rate of allograft rejection. With even if there is allograft rejection, there is few impact, and there is no effect on survival because it's possible to treat it. So clearly, I'm sure that in the future, with more and more, we see that we combine immunotherapy and liver transplantation, and probably for patients with PVT and HCC. The question is that. The question is, it's my patients, it's a patient of my group. You see, it is a male of 68 years old, normal liver, and infiltrative HCC on HBC pathological liver disease with a massive low alpha-fetoprotein, but a massive portal vein thrombosis until the portal trunk. And we are not 6 years, but 3 years of atezo-bev and atezo alone from 2 years. And now, 3 years after the starting of the treatment, we have no disease, very early and prolonged massive response. The patient is listed for 3 months without treatments. But now what we do? We do nothing, or we consider have been cured by the treatment, or we list the patients. And today we list the patient, but to be honest, we don't know exactly what to do. And perhaps the patient has been totally treated by the immunotherapy, but we decided to transplant the patient. And obviously, technically, it is a little bit tricky because there is a portal cavernoma, and we need to implant on the root of portal trunk, but it's not so hard. So clearly, I think in the future, we will see more and more such type of patients. So my conclusion, in the 90s, we transplant patients with small and limited number of tumors because we have no other method to select patients without extrahepatic disease, because the CT, the RMI was not sufficient quality, and there is no PET scan. In 2000, there is progress of local regional treatment with STACE, RF, TARE, external radiotherapy that enlarge the door of liver transplantation using downstaging. And downstaging is very efficient to exclude patients with extrahepatic disease using the test of time, because obviously when you treat a patient with STACE or local regional treatments, you treat only the liver, and if there is something outside, it's progress, so it's a way to select. You treat tumor with favorable biology, because it's have been demonstrated that the pathological response was very, very efficient to decrease the recurrence. So clearly there is an impact. But in the future and today, I think that the progress of systemic treatment will perhaps justify liver transplantation with any limits of the tumor burden, especially if there is no extrahepatic disease, but only after a long period of response, or perhaps we use useless liver transplantation if the patient is totally cured by medicine. To be honest, we don't know exactly what is the future today. But today, I think it's possible to say that active VP4, alpha fetoprotein, that more than 1,000, and extrahepatic disease, no liver transplantation, clearly, but after the staging, we don't know exactly what to do, but for the moment, I think we need to transplant patients that respond. Thanks a lot.
Thank you very much.